I think it's important to use more accurate terms in describing periodontal plastic surgery compared to the terms that are currently in the literature. My rationale for this is I'm a great supporter of the late Dr. John Pritchard, who was a stickler for nomenclature. In this video, I dedicate to him because his ideas are very much incorporated in this. Term number one. The current term is free gingival graft. A preferred term on that, or the proposed term, is the epithelialized palatal graft. Here's my rationale. The word free is redundant because a graft by nature is free. In other words, it is detached. Additionally, the term free certainly is not a scientific term. Term number two. The current term is connective tissue graft, CTG. I think a preferred term would be the subepithelial connective tissue graft. Here's my rationale. This is a non-epithelialized graft, which is distinguished from the epithelialized palatal graft. There are two types of tissue below the epithelium. There's connective tissue and submucosa, and the object is to harvest the connective tissue and not the submucosa. Term number three. The current term is coronally advanced flap. The proposed term is a coronally positioned flap. The rationale is to advance means to move forward. In this procedure, which I think is the simplest root coverage procedure, the flap is not advanced forward, but it is positioned coronally. And here we see an example of recession and superficial caries, and we can see where we have coronally positioned that flap. Term number four is a companion term to term number three, the coronally positioned flap. Currently, we use the term lateral sliding flap, or some people even refer to this as a pedicle graft, and it's certainly not a graft because it is a flap. The proposed term is a laterally positioned flap, which is a companion term, as I said earlier, to the coronally positioned flap. Here's my rationale. Pedicle means little foot. That means that you're stepping the tissue in some different direction. In this, you're stepping the tissue laterally. In the coronally positioned flap, you are stepping it incisally. So let's be more accurate in talking terms of the laterally positioned flap. So let's look at this. Here we see a lateral positioned flap done on the canine and a coronally positioned flap done on the premolars. So we can combine these to get the aesthetic result that we want. Term number five, proposed term obliquely positioned flap. This is a new term, and the rationale is that this is a coronally positioned flap that is positioned obliquely in the maxillary central incisor area so as not to coronally position the frenum. Here we see recession on a central incisor, and we are coronally positioning the tissue in an oblique position to gain the root coverage that we desire. Please note that the incisions are parallel and oblique, and notice that they do avoid the frenum, which we do not want to coronally position. Term number six. The current term is the apically repositioned flap. The proposed term, which is now used by many people accurately, is the apically positioned flap. The rationale. The proposed term has two applications in periodontal surgery. The first is in pocket elimination to preserve keratinized tissue. The second is in apically positioning the keratinized tissue when exposing a maxillary canine in orthodontics. And here we see an apically positioned flap for pocket elimination in the lower anterior area. Term number seven is a pet peeve of mine because we as periodontists and general dentists often talk about the gummy smile, and patients understand what that is. But let's be scientific and use a more scientific term, excessive gingival display, which is exactly what we're talking about. The rationale, as I say, gummy smile is not a scientific term. Excessive gingival display is, and I would urge you to use that, and let's get the scientific literature out there. On the left, you see the excessive gingival display, which was treated by crown exposure, not crown lengthening, because what we have uncovered is that beautiful enamel and the aesthetic impact is quite vivid. Term number 8 is a companion term to term number 7. The current term is crown lengthening surgery. The proposed term is crown exposure surgery. Now here's my rationale. The cemento-enamel junction defines the anatomical crown of the tooth. The crown is not lengthened, but this procedure exposes the anatomical crown. There are two types of crown exposure surgery. One is for aesthetics, and this is typically done in the maxillary arch, especially the maxillary anterior. And the other one is for function, where we fractured a cusp and we're doing crown exposure surgery to enhance the restorative. And on the left, you see the excessive gingival display and the fantastic aesthetic result that was gained when those anatomical crowns were exposed. Term number 9 I found very difficult to redefine. The rationale. When doing frenal surgery, the frenum is not always removed. Sometimes it is repositioned, and by grafting, attached gingiva is created incisally. In the maxillary arch, frenal surgery generally involves much more than a simple frenectomy to maximize the aesthetic result and to prevent the dreaded black triangle. Now let's look at what I'm trying to define in a couple of pictures. Now let's see if we can define and clarify this for you. In this case, the frenum is exactly where it's supposed to be. It's at the mucogingival junction. But it is a problem, and it is aberrant because recession has come down to the frenum and there's probing depth on the facial, so we have an unhealthy situation. You will notice that the area has been flapped back, but the frenum has not been removed. And we've placed connective tissue there, and hopefully we're going to gain attached gingiva incisal to that at the cemento-enamel junction. Here we see about a 25-year post-op, and note that we do have keratinized tissue regenerated incisal to that frenum. But the frenum was not removed, so the term frenectomy would be inaccurate in this particular case. This would be a plasty or a frenotomy, I think would be the more accurate term. Here we see the free gingival groove, and we see an adequate area of attached gingiva. Here is the maxillary arch, and you will notice that the papilla between the central incisors appears to be frenal tissue. Yes, we're going to do a frenectomy, as you're seeing here, but please note how we're taking that Bard-Parker 12B blade and not removing the frenum, but doing a plasty to reshape the frenum. And now we're doing a laterally positioned flap, and the frenum has been removed, but then we've done plasty on the papilla, and you will see here where we gained a nice aesthetic result by doing a very sophisticated procedure rather than a simple frenectomy in the maxillary arch. 2 thumbs up for Joe Califano for bringing this to my attention. Term number 10. We use the term biologic width. I propose the term biologic length. Now, I did have some discussion with my friend Pat Allen, and he said this should be biologic height. But we don't talk about the height of a tooth, we talk about the length. That is why I've chosen the term biologic length rather than biologic height. The rationale. Violation of this dimension, as all periodontists know, creates a periodontal problem. This is a vertical component and not a width component, hence the term biologic length rather than biologic width. In this case, we see excessive gingival display, and we're going to have to remove bone in this, and you will note that the biologic length in this tooth is 3 millimeters, and we need room for attachment sulcus depth as well as crown exposure. Term number 11. The misused term mucogingival surgery or soft tissue surgery. The proposed term is periodontal plastic surgery. The rationale. The term mucogingival surgery, in my opinion, has been antiquated for over 30 years because mucogingival surgery was designed to get a functional result, whereas periodontal plastic surgery is designed to gain a functional and aesthetic result. And for residents watching this, they need to have a reference which they can use for their boards. And here's the reference from the 1950s by Friedman on his definition of mucogingival surgery. And here is the definition that I submitted to the dental clinics of North America, where we define periodontal plastic surgery. And certainly don't talk in terms of soft tissue surgery, because we do soft tissue surgery on every part of the body. So let's not use the term mucogingival surgery, use the term periodontal plastic surgery. Now, periodontal plastic surgery is done on mucogingival defects. So don't hesitate to use the term mucogingival defects, but don't talk about doing mucogingival surgery. I hope that you can see the rationale and reasons for making these suggested changes. And I'd like to thank Dr. Califano for his suggestions on there, and also 2 thumbs up for the input that my friend Pat Allen made in these terms. For in my opinion, Pat is the world's premier periodontal plastic surgeon, and I think if he had served on the World Workshop, the classification of recession would be more clinically meaningful.